You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 15th, 2023. This week, I will do some reader feedback, imaging in the Cath Lab, AF ablation to relieve anxiety, and maybe some coming help in hypertension. First up is reader feedback. Dr. Tim Balthazar, a cardiac intensivist, pushed back on my coverage of the ECLS shock trial last week. Now, ECLS shock was VA ECMO versus standard care, and it found no benefit and increased harm in the VA ECMO group. Dr. B made the point that ECLS did not recruit patients most likely to benefit, specifically that many patients were resuscitated, have a Sears-like syndrome, and these patients most often respond to IV fluids and maybe not VA ECMO. And some of these points about patient selection were actually made by the discussant at ESC. My response to this feedback is to first thank Dr. Balthazar for taking the time to write and listen. His point centers on patient selection. In short, they did not select the right patients, for if they had, the treatment would have worked. Now, this is a common criticism of trials that come up with non-significant or null results, and my general answer is that A, when we translate evidence, we must always consider for whom the evidence applies. B, proponents of therapies that are shown ineffective bear the brunt of proof. If, in the face of one or more non-significant trials, proponents believe that something works in specific patients, and the onus is on those proponents to show it does pass muster in some population of patients in a proper trial. Second reader feedback, Dr. Evan Schreier also took issue with my commentary on ECLS shock. Dr. S. wrote, quote, I believe you may have over-extrapolated by saying that all mechanical support may not work in MI-related cardiogenic shock. He then went on to describe some of the weaknesses of VA ECMO relative to other forms of mechanical support. My response is that I am not exactly sure what I said, but what I wrote in the script, which I don't always follow, was this. I wrote, quote, I also think ECLS shock puts a serious damper on mechanical support of any sort, though we await the Impella trials before making any judgments based on observational data. And one of the more important Impella in cardiogenic shock trials is called Danger Shock Trial, which the authors write will be properly powered for outcomes. And I'll link to that. Another note to Dr. Schreier, I hope all is well at Hartford Hospital. As a UConn medical student, I have fond memories of rotating there. Okay, final feedback. I'm going to mispronounce this name, but Dr. Aslanif Roslin inquired about my thoughts on CTO PCI, that is chronic total occlusion PCI, and I refer listeners here to my coverage of a flawed analysis, meta-analysis on the August 11th, 2023 podcast. I also wrote commentary on the first CTO PCI trial called Decision CTO way back in 2017, and I'll put a link in the notes. The short story is that CTO PCI needs a lot more randomized controlled outcomes data. All right, next topic. First topic really is imaging in the Cath Lab. Two big trials presented at ESC and published in the New England Journal of Medicine address the use of imaging to better place stents in the Cath Lab. Now, I cover this topic as a neutral Martian looking in at the data. There are corollaries, however, in electrophysiology. We have a number of costly add-on tools to use in our labs, which the profit-driven companies say will improve our procedural success. But one laudable fact is that at least in interventional cardiology, they are putting these add-on tools to the test of the RCT, and I say good on them for doing it. Now, some brief background. PCI has come a long way from the days of plain old balloon angioplasty. Stents have iterated a lot, but another way to improve PCI results is not just in the actual stent materials, but its placement in the coronaries, and coronaries are far from inner tubes. So the goal of imaging, and in the case of the October and Illumin 4 trials, optical coherence tomography, or OCT, the goal of these is to better place the stent, and this should lead to better clinical outcomes. Like the use of intracardiac ultrasound should lead to better AF ablation outcomes. So the Illumin 4 trial randomized nearly 2,500 patients who had diabetes or complex coronary lesions to one of two arms, PCI guided by OCT or PCI guided by plain old angiography. They had two primary endpoints. One was an imaging or surrogate endpoint, and one was a clinical endpoint. Surrogate endpoint was minimum stent area measured in millimeters squared. The clinical endpoint was a composite called target vessel failure at 2 years, and this included important things like CV death, MI that occurred in the stented vessel, or revascularization due to ischemia in the treated vessel. Now, the first primary endpoint of the Illumin 4 trial favored the OCT arms. Minimum stent area was greater by 0.36 millimeters squared. That was better in the OCT arm. That was highly statistically significant. It's hard for me to make much of that, but the clinical endpoint, which seems more important to me, was not different statistically. Target vessel failure within 2 years occurred in 88 patients in the OCT group and 99 patients in the angiography group. That is 7.4% versus 8.2%. The hazard ratio was 0.90, and the 95% confidence intervals went from 0.67 to 1.19 with a p-value of 0.45, so not even close to statistical significance threshold. Now, the OCT-related adverse events were not different, but one notable observation in Illumin 4 was stent thrombosis. Stent thrombosis within 2 years occurred in 6 patients. That's 0.5% in the OCT arm versus 17 patients, 1.4% in the angiography group. The p-value in New England Journal was listed as 0.02, but it's one of many endpoints. And these are small numbers of events, and this stent thrombosis data could be statistical noise, but stent thrombosis is the most feared complication of PCI because you go from 0% obstruction to 100% obstruction, and patients do badly with this. Think MI and or sudden cardiac death due to VF. The October trial, second trial published and presented at ESC, randomized 1,200 patients who had complex bifurcation lesions to either OCT-guided PCI versus angiography alone. And they had only one primary endpoint, and this was a MACE endpoint defined as a composite of CV death, target lesion MI, or revascularization due to ischemia, and this was at 2 years. And the results favored the OCT-guided PCI. At 2 years, 10.1% of the patients in the OCT arm had had a primary outcome versus 14.1% in the angiography alone arm. That's a hazard ratio of 0.70, and the confidence intervals range from 0.50 to 0.98, and the p-value snuck in at 0.035. All components of the primary outcome contributed to this reduction, and definite or probable stent thrombosis here, the events were low and really kind of similar in both arms. Procedure-related complications were slightly higher in the OCT arm, 6.8 versus 5.7%, so that's 1.1% higher in the OCT arm. Journalist Steve Stiles had coverage of these sessions. His report, as always, is excellent. He also covered a network meta-analysis that was presented during the same session. The meta-analysis was presented by Dr. Greg Stone, and it included the Illumin 4 October and 18 earlier outcome trials that compared PCI guided by IVI, intravascular imaging, and that could have been either OCT or IVIS, intravascular ultrasound, versus angiography only PCI. This meta-analysis covered more than 12,000 patients, followed for a mean of 26 months. Patients were assigned to either imaging-guided or angiography-guided PCI, respectively. I've not seen publication of this paper, so I'll keep the report brief. In general, image-guided PCI did better on major clinical outcomes, especially stent thrombosis. Okay, my comments. Steve Stiles really covered this debate, this issue in his news piece, and that is proponents of imaging, specifically OCT, think it should be used more often. They feel that the extra cost, contrast, X-ray exposure, and maybe slight increase in procedural risk justifies its use. And I say, at least we have data to have a debate, unlike in electrophysiology. October trial finds a clear signal of better outcomes. Illumin 4 did not. I discount Illumin 4's imaging primary endpoint as a simple surrogate. Both trials, however, list as limitations that you cannot control for performance bias, and that is that the interventional cardiologists in these trials are not blinded. Many of these doctors may be proponents of OCT. They may use super extra caution in the OCT arm, but they also may be using super cautious in the techniques in the control arm as well. The point is they're not blinded. The positive October trial, though, has a whopper of a limitation. Quote, this is from the paper, quote, patient eligibility was verified by on-site investigators and not by a centralized core laboratory. That should alert you to the possibility of selection bias, meaning that doctors, including or excluding patients based not on randomization, but other specific characteristics. In sum, I am not sure the imaging data are strong enough to warrant solid recommendations in the guidelines as in do this. Because if that was in the guidelines, this could lead to a change in the standard of care. And if you don't use imaging and your patient has a bad outcome, boom, you could be liable. However, there surely seems enough signal in these trials to warrant use of imaging in difficult lesions. How about I say this? How about we say we rely on super skilled operators to choose the most effective and safest way to perform PCI? In an ideal world, such things as cost constraints would not affect these decisions. It would only be about patient outcomes. But of course, we do not live in this ideal world. I would also add the caveat here that I trust that these patients undergoing PCI are not patients with stable coronary artery disease that could have been as well treated with optimal medical therapy. And final comment, again, back to EP, I'd love to see the electrophysiology community do a similar study looking at heart outcomes of, say, intracardiac echo for AF ablation. I wonder what those results would be. In many cost-constrained systems, intracardiac echo imaging is not used. In the U.S., ICE has become the standard of care, and if you don't do it and have a bad outcome, you can be sure that an American colleague will testify against you in a malpractice suit. All right, next topic is a trial called the Remedial Trial, published in JAMA. Now, the crazy thing about atrial fibrillation is that it causes so many different kinds of symptoms. Some patients have no symptoms. Some can be totally disabled. Those with heart failure may decompensate rapidly. We've talked about that recently. Most patients with AFib are somewhere in the middle, between zero symptoms and totally disabled. But it gets even more complicated than physical symptoms because AFib not only reduces cardiac output, not only induces funny sensations in the chest and reduces vigor, but that pesky rhythm can also mess with your psyche. I know this firsthand. Even as an electrophysiologist, AFib, when I had it messed with my head, I became anxious and I got down. Had you formally assessed my anxiety and depression scores during the year or so that I had atrial fibrillation, I would have scored poorly. And I see this often in the AFib clinic. Multiple times per day, I tell patients that I am a cardiologist, but I am also their psychologist. EP doctors who care for patients with AFib spend oodles of time reassuring, educating, and counseling patients. The take-home of all this is that we will help them, and this is what I say. The psychologic disruptions of AFib are underplayed, I think, in cardiology circles. And good health is surely more than physical things like your heart rhythm. Now, a group of famous researchers from Australia decided to formally study the psychological aspects of AFib, including the effects of AFib ablation. And empirical study is something I always favor. Sadly, though, their study, called Remedial, was published in JAMA, could not answer the question they wanted to answer. The first author here was Ahmed Al-Kaisi. In the Remedial trial, which was done at 2 centers in Australia, 100 patients with symptomatic AFib were randomized to have AFib ablation or take antiarrhythmic drugs. The primary outcome of this trial were scores on the hospital anxiety and depression scale at 1 year. This is a validated multi-question assessment. Now, pause there for a moment. Stop and think. Remedial is going to measure a subjective endpoint, anxiety and depression. And one group gets an invasive procedure and the other group does not. Now, here are the results. The combined score was lower in the ablation group versus the medical group at both 6 months and at 12 months. The between group differences were highly statistically significant. AF ablation did better. And another secondary measure that measured psychological distress also favored ablation. And of course, as it has been shown in many studies, AF ablation reduced the amount of AFib episodes versus antiarrhythmic drugs. Now, the median AF burden in the ablation arm was 0%. The median AF burden in the drug arm was 15%. And the authors concluded in JAMA, quote, in this trial of participants with symptomatic AF, improvement in psychological symptoms of anxiety and depression was observed with catheter ablation, but not medical therapy. Now, let me also read you their first 2 sentences in the limitations paragraph. Quote, first, participants were not blinded to treatment assignment. Therefore, the possibility of differential procedure-related placebo effect on study outcomes could not be ruled out. A larger multi-center study with a sham group would more completely answer this question and further clarify the mechanisms associated with the improvement in mental health, end quote. Okay, my comments. I think the world of these researchers. They are some of the smartest people in our field. They've contributed immensely. They've done practice-changing research, but this is not that. I 100% agree with their limitation statement in saying that you need a sham group. Come on, the only way to assess a subjective endpoint such as anxiety and depression is with a proper control arm, and that would mean a true sham procedure. I've spent many hours delving into the literature on placebos and nocebos. I have a talk on it. Something as simple as the color of a pill can affect subjective outcomes. So clearly, an invasive procedure puts out a much larger caring signal than does pills. This trial, this study, is faith healing and subtraction anxiety on steroids. What's more, having done ablation now for 20 years, I can tell you of many cases of people who still have the same amount of AFib, sometimes more AFib after ablation, who have much better psychological health. What's also surprising to me is that the accompanying editorial hardly mentioned this major limitation. In the care of patients with AFib, attention to mental well-being is critically important. AFib doctors must be teachers and psychologists. Addressing the anxiety and depression that often comes with AFib is a core tenet of what we do. And I believe that catheter ablation has its role. I do remain highly suspicious of quality of life data after ablation. I do AF ablation regularly because I believe that it has some component of a placebo-resistant effect. What that percentage is, I don't know. It remains a mystery. For instance, I also do cardiac resynchronization therapy, and I would have thought that the placebo-resistant effect of CRT would have been much larger than just 16%, as shown by an extremely well-done meta-analysis by Afzal Sohab and Daryl Francis, which was published in the European Heart Journal in 2013, and I'll link to that. Finally, I just need to say that I worry a lot about the overuse of AF ablation, especially in the U.S. Positive media coverage of this paper, its publication in JAMA, could only worsen that. Relief of anxiety and depression is really important in our field. But if we want to say that ablation does that, then we need a proper comparison and control arm. And procedure versus medicines is just not that. Okay, next topic, final topic, are new antihypertensive drugs. And this is the Target Hypertension trial. Now, this coverage is going to be brief because Target Hypertension was a phase 2 dose-finding study. Phase 3 trials study clinical outcomes, are what I usually cover on TWIC. But JAMA's publication of the Target Hypertension trial deserves mention because A, hypertension is such a huge problem, and B, Target Hypertension studies a novel drug that blocks aldosterone synthesis. Now, a couple of notes on aldosterone. I often refer to spironolactone, a mineralocorticoid receptor antagonist, as my secret weapon for both patients with HFpEF and hypertension. The role of high levels of aldosterone in hypertension, especially resistant hypertension and hypertension obesity, I think is underappreciated. A quick story. Back in the 1990s, when I started private practice, I remember a Monday morning encounter with one of my senior partners, Dr. Richard Allen, who we called the General because he was the group leader. Dr. Allen took me aside and said, "John, that older lady with tough blood pressures and vascular congestion that you all were struggling with, you should have started her on mineralocorticoid receptor antagonist." I'm like, oh, okay. From then on, I tried it, spironolactone. I never forget to think about using spironolactone in these patients. Well, Target Hypertension studied perhaps a better way to deal with aldosterone's role in hypertension. Instead of blocking the mineralocorticoid receptor, the drug lorundrostat inhibits aldosterone synthase, and the drug looked promising. In patients with hypertension, despite 2 background medicines, the mean reductions in systolic blood pressure in the drug were in the range of 10 millimeters of mercury. Only a handful of patients had hyperkalemia. The conclusion is that lorundrostat looks promising enough to move on to phase 3 trials. A news column on the heart.org Medscape Cardiology from Megan Brooks also tells us of another aldosterone synthase inhibitor called baxdrostat, which also looks promising. Now, both agents are a little bit ways from clinical use, but both look to have larger blood pressure reductions than the sadly modest and short-term drops seen with renal denervation. So it's something to be noted and potentially excited about. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating. Even a 1 or 2 sentence reviews, these things help us quite a bit. We're approaching 700 ratings on Apple Podcasts, so I'm pretty excited about that. So be sure to take the time to make a rating or write a review. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.